A vessel in the brain just burst, and this is the one stroke where a clot-buster would be an absolute death sentence. Welcome to The Explainer. Today, we're mastering the most highly tested med-surg concepts for hemorrhagic stroke. Let's get into it.
Section 1. The burst. Let's look at the pathophysiology.
So the path of destruction here kicks off when a cerebral vessel ruptures. We're usually talking about chronic uncontrolled hypertension, maybe a weakened aneurysm or an AVM, an arteriovenous malformation. Step 2. The blood rapidly accumulates and forms a hematoma. Now remember, the skull is a rigid, closed box, right? It doesn't expand. So we hit step 3. Pressure rises. That extra volume drives up intracranial pressure, or ICP, and literally crushes the surrounding brain structures. We call this a mass effect. Moving on to step 4, this rising pressure drastically lowers cerebral perfusion, leading straight to ischemia. And finally, step 5, the ultimate danger. If this whole cascade isn't stopped, you're looking at brain herniation, deadly rebleeding, or massive vasospasms.
Now we've basically got two main culprits to worry about here. First up is intracerebral hemorrhage, or ICH. This is bleeding directly into the brain tissue itself, mostly driven by chronic uncontrolled hypertension. Then we have subarachnoid hemorrhage, SAH. This is bleeding around the brain in the cerebral spinal fluid space, and it's usually triggered by a ruptured cerebral aneurysm.
Section 2. The clues. What are the signs and symptoms?
The absolute hallmark sign to watch out for is a sudden, severe thunderclap headache. If your patient suddenly screams that they're having the quote-unquote worst headache of their life, you have to suspect a subarachnoid hemorrhage until proven otherwise. As that intracranial pressure rises, you're going to see a decreased level of consciousness, unexplained vomiting, seizures, and focal deficits, like sudden weakness on one side. And specifically for SAH, really look out for nuchal rigidity. A stiff neck is a massive red flag for meningeal irritation from all that blood. Imagine the sheer panic of a neuro ICU nurse seeing these signs cascade. It means the clock is aggressively ticking.
But listen up, because here is a late-stage danger you absolutely cannot miss. Cushing's triad. It's a combination of bradycardia, irregular respirations, and a widening pulse pressure, meaning those systolic and diastolic numbers are moving further and further apart. If you see this triad, brain herniation is imminent. It is a massive clinical emergency.
Section 3. Danger. Here is the absolute rule.
Let me be crystal clear here, and I really want you to burn this warning into your memory. A hemorrhagic stroke is active bleeding in the brain. So no tPA, no anticoagulants like heparin, and no antiplatelets. Giving a clot-buster to a patient who is actively bleeding into their brain is, quite literally, a death sentence. Thrombolytics are strictly 100% contraindicated.
Section 4. Priority nursing interventions. Let's save this patient.
We're working in strict priority order here. Number 1, secure the airway and breathing and rush them for a stat non-contrast CT of the head to confirm the bleed. Number 2, stop the bleeding. We do this by reversing any anticoagulants the patient is already on, and we carefully lower their blood pressure to stop that hematoma from expanding. Number 3, manage that rising ICP. Elevate the head of the bed 30 degrees, keep the head midline, and strictly avoid any straining or bearing down. Number 4 is SAH specific. We administer nimidipine. And finally, number 5 is definitive surgery, like a hematoma evacuation or aneurysm clipping and coiling.
So when you order that stat non-contrast CT, the fresh blood is going to show up as bright white or hyperdense. That confirms your diagnosis. If it turns out to be a subarachnoid hemorrhage, you'll reach for nimodipine. Why? Well, nimodipine is a calcium channel blocker that prevents those deadly cerebral vasospasms that love to happen around days 4 to 14 after the initial bleed. And lastly, have your reversal agents ready to go. Vitamin K, protamine, whatever matches the patient's current anticoagulant therapy.
Okay, let's do an NCLEX check. Time to test your active recall and see if you caught the key traps.
Question 1. A client with a confirmed hemorrhagic stroke is agitated. Which order would the nurse question? Is it A, B, C, or D? Drop your answer in the comments right now. 3, 2, 1.
The answer is C. Administer alteplase. The prompt asks what order you'd question, meaning which one is flat out wrong or dangerous. And as we just established, clot-busters like tPA are entirely contraindicated for hemorrhagic strokes because they will drastically worsen the bleeding. You have to question this order immediately. Let's try question 2. Which intervention helps prevent increased intracranial pressure in a client with hemorrhagic stroke? Check out the options and lock it in. 3, 2, 1. You got it. The correct answer is A. Keeping the head of the bed elevated 30 degrees and keeping the neck perfectly straight promotes venous drainage right out of the head, which effectively lowers that intracranial pressure. On the flip side, encouraging them to bear down, clustering way too much care at once, or overstimulating the patient with bright lights, yeah, all of that will dangerously spike the pressure.
Let's wrap this up with your golden rules. Worst headache of your life means subarachnoid hemorrhage until proven otherwise. A confirmed active bleed means an absolute no to clot-busters. And nimodipine prevents vasospasm in SAH. If this made it click, subscribe. One killer med-surg topic every day until you pass the NCLEX. But before you step onto the floor, ask yourself, if your patient's stroke symptoms are ambiguous and the CT scanner is down, how do you know if you're about to save their life or administer a fatal dose?